Patrick, thank you for that very kind introduction, and I would like to thank H.I.T Training for the invitation to visit Dresden and participate in this very interesting and exciting Congress. This is my 5th opportunity to visit Germany. It's a beautiful country. I'm glad to be back, and thank you all for coming. I would like to talk a little bit about the prescription of resistance training for the prevention and rehabilitation of low back pain today, and would first like to consider the epidemiology of low back pain, and then discuss some of the challenges associated with exercising the lumbar extensor muscles, which are relatively weak muscles and present some unique challenges in terms of isolation for effective training. Then we can discuss the physiology of lumbar extension strength training and why it's important in the prevention and rehabilitation of back pain. I do have some clinical supporting evidence that I hope you'll be interested in. And time permitting, I would like to get into the guidelines associated with resistance training, specifically some of the contributions that strength training has to the health benefits of participation in physical activity. But if we don't get that far, it's okay. You'll have the slides in the presentation. I'll be glad to send them to you. And I believe just about everyone in this audience understands that a single set of quality exercise can produce both fitness as well as health benefits. So, low back pain is a big problem. It's a big medical problem in all modern industrialized societies. 80% of all individuals at one time or another in their lives will experience an episode of low back pain. And 20% of these cases will become chronic. It's a leading cause of physician visits, in some studies second only to the common cold for going to visit your doctor. It's a leading cause of disability and time lost from work. In some studies, it's the #1 cause of disability. And estimated annual medical costs exceed $50 billion a year. That's billion with a B. Now, one of the problems associated with low back pain and other hypokinetic diseases is that the disease leads to a disability, which then results in more physical activity, which further exacerbates the disease, and we get into this vicious cycle called the disability syndrome. And so unless we can break this cycle, we're destined for ongoing medical problems and medical costs. And one of the best ways to break the disability syndrome cycle is right here. By not becoming inactive, not letting the disability result in additional physical inactivity. This is a model developed by Jim Rimmer that shows the consequences associated with significant physical disability. And over time, we know that strength will decrease. It doesn't have to. If we participate in properly prescribed activity programs, we can maintain strength. But very often strength does decline due to physical activity, decline in physical activity. And we can see here that those individuals who are able to maintain a certain level of functional strength are able to participate with functional dependence, but once we cross this threshold, we're no longer able to complete normal activities of daily living or the instrumental activities of daily living. And the take-home message here, the bottom line is, here's where we start to decline in quality of life. So individuals who are able to maintain functional capacity can maintain a healthy quality of life, and if we're not able to do that, we begin to compromise a quality of life. The etiology of low back pain is diverse. There are many things that cause low back pain. And it's very difficult to treat something when it's hard to identify what the cause is. As a result, there are many different kinds of treatment for low back pain. And these treatments range from relatively conservative care, physical therapy, including the McKinsey approach, to very aggressive care, spinal surgery, for example. And remember, there's no guarantee that the more aggressive approaches are going to be effective at eliminating back pain. Individuals who undergo surgery are just as likely to experience recurring episodes of low back pain as anyone else. And this is an important question. Do we experience back pain because we're all walking around with weak backs? Or do we end up with weak backs because there's an injury there? One thing for certain, we know that orthopedic injuries occur when the forces associated with physical activity exceed the integrity of the orthopedic joint system. And so if we can improve the structural integrity of an orthopedic area, we're better able to withstand the forces that occur, less likely to become injured. Now, this is not a new concept. These are pictures of exercise equipment that was developed by a Swedish physician, Dr. Gustav Zander, in the 1800s. And he understood that if we can exercise the low back, we can have a positive impact on functional capacity and potentially reduce low back pain. And I understand that some of these pieces of equipment, or equipment like it, is located right here in this museum. And so I'm very excited after this conference to visit the museum and see some of these pieces of equipment. But one of the problems associated with the lumbar extensors, or the paraspinal muscles, is that they work in conjunction with the larger, stronger gluteus and hamstring muscles during compound trunk extension. So when the pelvis is allowed to rotate, the gluteus muscles, the hamstring muscles are the prime movers for that kind of an activity. And the lumbar extensor muscles, the paraspinal muscles, which are muscles associated with postural control, come into play only when we can restrict pelvic rotation and the elimination of the contribution of the prime movers. And there are fiber type composition data, muscle fiber type data that support this. So here's a slide of fiber type composition of the lumbar area, and a couple of things we can notice. It's primarily type 1 or slow twitch muscle fibers, both in terms of size of the fiber and proportion. That the slow twitch muscle fibers and the lumbar extensors are greater than slow twitch fibers located in other muscle groups. So they're designed primarily for postural control and therefore relatively deconditioned. They don't undergo forces associated with activities of normal daily living, lifting, those kinds of things. And so the idea is to develop a strategy by which we can target these muscles for effective training. Now, what often happens when we become tired and fatigued, when the prime movers all of a sudden biomechanically change the strategy with which they're being called upon to lift. We expose the back muscles, the weaker muscles designed for posture control for these larger forces. And all of a sudden we're asking them to do more work than they were designed to do. This is Arthur Jones. He's been mentioned a couple times already. And I had the privilege to work with Arthur when I began my career. Arthur, of course, is a pioneer in the development of exercise equipment. He's also a pioneer in the development of the way that we exercise. He understood that less can be more, and that it's the quality of exercise that's most important, not the quantity. He also understood that direct resistance must be applied to a muscle in order to effectively train it. And this makes sense from a global perspective. If we want to strengthen our legs, for example, we're not going to exercise the arms, right? We need to target the leg muscles. And so if we want to strengthen the muscles of the low back, we need to target them. And again, it's difficult because they work in conjunction with other muscles, which are the prime movers for compound trunk extension. He also understood that resistance varied through a range of joint motion, and this is an important concept for training particular muscles. Now, I was very fortunate because when I was working with Arthur and others, he had all these ideas. He was ahead of his time. Arthur had an 8th grade education, not beyond, but understood all of these physical concepts associated with motion and exercise and the physics associated with physical activity. And I had so much fun because a lot of the work that I did was designed to test Arthur's theories. And in just about every case, he was correct. And I'll show you some evidence of that in just a minute. The one thing where he was off just a little bit, and not by much, was that if we exercise through a partial range of motion, in other words, not through a full range of motion, and full range of motion, physical activity is important. I don't want you to misinterpret the point I'm trying to make here. We should exercise through a full range of motion. But if we can't, or if we don't, as often happens in patient populations when range of motion is limited, there is carryover from the exercised area to the unexercised area. And so this is the restraint system that Arthur developed. It didn't look like this to begin with. All right, there were some prototypes along the way, many different models, but eventually it looked like this. And the idea was to drive the legs back into the pelvis so the pelvis could be secure against this pelvic restraint mechanism and a thigh restraint, so that the pelvis would be restricted with respect to its movement, and we could flex and extend using only the low back muscles. And one of the unique aspects of this particular design was that this pelvic restraint would rotate if there was any pelvic rotation. They worked like gears together. And if we were truly restricting pelvic rotation, this would be stationary during the physical activity, and that required cranking this footboard forward a little bit more than some people thought was comfortable, but in the end it was overall pretty effective, a pretty effective strategy. And this is a picture of what that particular lumbar extension dynamometer looked like using the restraint system. You can see it in place here. And this was after Arthur had left Nautilus and was developing the MedX exercise company. And so, the concept of exercising the back to develop functional capacity and to prevent back pain is not a new concept, but it certainly has evolved over time, hasn't it? From what Zander was thinking of back in the 1800s and what is currently in existence today to isolate the lumbar muscles for effective exercise training. I also had the privilege to work with Michael Pollack early on in my career. Mike was directing an exercise center at the University of Florida in Gainesville. And he directed the first series of studies designed to evaluate the physiology of effectively training the muscles of the low back. And I would like to share with you some of the results of those studies. So this is the first training study that we conducted out of the University of Florida in Gainesville. This was in the mid-1800s. I actually moved to Houston, Texas in 1985 to work with Mike there. He was directing a cardiopulmonary rehabilitation program. And we moved from Houston to Florida together in 1986. Exercise and aging was one of the areas we were very interested in, and of course through our association with Arthur Jones, studying resistance exercise. So this low back dynamometer was being developed down in Ocala, Florida, about an hour's drive south of Gainesville. And we would go down once a week to see how the development was coming and work on the design and even train on the machine. And so this first training study was with 15 subjects. I was one of them. We compared the results to a control group that didn't train, and we trained using one set of activity one time per week with a 6 to 15 repetition maximum load for 10 weeks. Now, why just one time per week? Well, we didn't want to go down to Ocala every day. We didn't want to go down twice a week. We didn't want to go down 3 times a week. But we were willing to go down once a week to see what was going on and train on the machine. We didn't know what was going to happen. And after 10 weeks, what we did was we looked at the isometric torque output tested at 7 positions through a 72-degree range of motion, which is accepted to be the full range of lumbar extension motion when the pelvis is restrained. So that's a normal range of motion. And we just tested at 7 different positions. A couple of things. You can see that the strength curve is ascending from the, let's see, this is the extended position to the more flexed position. And in the red here, we've got pre-strength measures and after training post. Now, the most surprising finding of this particular study, and again, this was the first exercise training study on isolated lumbar extension muscle strength, was that the torque output improved from 42% to over 100%. 42% here, over 100% here. So pretty large strength gain. I mean, we doubled strength in 10 weeks, exercising 1 time per week. Now, my opinion now, after conducting a number of studies in this area, is there's probably a lot of learning going on, how to use this machine, some neural factors involved, but nevertheless, fairly significant improvement in lumbar extension muscle output. So we thought, wow, if we're getting these kinds of strength gains training 1 time per week for 10 weeks, what if we train twice a week, 3 times a week? And so we did a frequency of training study after that where we compared the change in torque training every other week, once a week, twice a week, 3 times a week, to a control group that didn't train at all. And you can see it wasn't doubling the strength like we saw in the previous study, but nevertheless, pretty significant strength improvements, and it really didn't matter that much how many times per week we were training. A little bit of a, maybe dose response effect there, but still 30% improvement training every other week, up to maybe 40%. We were also very interested in understanding how important stabilizing the pelvis was for the effective training of this particular muscle group. And so we had a group train without pelvic stabilization and a group that trained with stabilization, change in strength, and you can see that if you train without stabilization, little to no change relative to a control group. With stabilization, isometric lumbar extension torque output of the isolated lumbar extensor muscles was much greater. So here we're training the prime movers. We're training the legs and the gluteus muscles. So we know that strength improvements occur from both neural and morphological mechanisms. The morphological changes occur as the muscle increases in size. And there are a lot of studies that have added to our understanding of how this happens. Historically, it's been thought that the increase in muscle size or the hypertrophy that occurs as a result of muscle training is exclusively from increasing the size of the fibers. But more recent studies have shown that there is, in fact, some fiber splitting that can occur, especially resulting from high-intensity kind of training. So as the studies become more sophisticated and the literature becomes more available, I think the jury is no longer out that there is documented hyperplasia or increase in the number of muscles that's occurring as well. And there are a variety of neural factors that are associated with the improvement in functional capacity or an increase in muscle strength. We can increase the number of motor units that are recruited, and Doug just mentioned that a motor unit is simply an alpha motor neuron in all of the muscle fibers that it innervates. And an alpha motor neuron that innervates a lot of muscle fibers is going to be stronger than an alpha motor neuron that innervates just a few muscle fibers. And prime movers have motor units with a lot of fibers, and the postural muscles have motor units with few fibers. So we can increase the number of motor units that we're recruiting, or we can recruit motor units at a greater frequency, right? They're turned on, they're turned off, they're turned on, they're turned off. If we do that more quickly, we will generate more force. Or we can increase the synchronization of motor unit firing. In other words, if we take more motor units and recruit them at the same time, we're going to be able to generate more force than if some are turned off at one time and some are turned on at another time. And we can measure the neural contribution to muscular force output through a technique called electromyography. It's simply a technique where we place an electrode either inside the muscle or over the surface of the muscle and measure the electrical activity that's delivered from the central nervous system, where movement originates, to the muscle that is moving. It's a relatively crude measure, but what it gives us is an indication of the neural drive to the muscle, the overall electrical activity that's delivered to that muscle to make it move. Now, clearly movement patterns are complex and very sophisticated with respect to the pattern of movements that are occurring. So we're not talking about motor control here. We're simply talking about the neural drive to the area to elicit movement in the first place. And we can use electromyography to determine how much of an increase in force is due to electrical contributions. So this triangle up above the white line here on the far right would be that increase in force that's associated with increased neural drive or EMG activity. But notice here we have some increase in force that's due to other factors. These other factors are due to the skeletal muscle hypertrophy that's occurring. And this is a very elegant technique that was developed by Motoren and De Vries some years ago, and is still used today. And we know that early on in training, most of the contribution in functional capacity or an increase in strength is due to neural factors. So very early on, it's the nervous system that's contributing to strength gains. Later on, it's morphology or muscle hypertrophy. And this is an important concept because if we believe that preventing orthopedic injuries is associated with improving the integrity of the orthopedic joint system, increasing muscle size, increasing bone density are all going to be important factors, and I'll come back to that. So this next series of slides represent studies that were designed to determine the neural versus morphological contribution to the increase in functional capacity associated with isolated lumbar extension strength training. This is some work out of my lab at Syracuse University after I had left Mike's group at Gainesville. One of our doctoral students, a chiropractor named John Mayer, he looked at people who were exercising using a Roman chair device, training on a lumbar dynamometer with pelvic stabilization, and training on a dynamometer without stabilization. And we tested people under two conditions. We test them, one with no restraint and one with pelvic restraint. And you can see when you're tested without restraint, really doesn't matter if you've trained at all, because you're testing the strength of the prime movers. But when we tested in the restrained condition, you can see that training with pelvic restraint produced much greater improvements than certainly control and some of these other methods, training with no restraint or even on a Roman chair. Now, subsequent studies have shown that if we pay attention to what's happening to the pelvis during exercise on Roman chair exercise, we can actually improve this a little bit. But you've got to consciously be aware of how it is you're training and how your body is working. But with good coaching, we can minimize the rotation associated with gluteus and hamstring muscle activity and get even greater. And so that point is, if you don't have a very expensive lumbar extension dynamometer equipped with a restraint system, you can use other devices if you understand the biomechanics associated with the physical activity and how to work within that. This is an early study by Dan Foster, one of our students, and he used magnetic resonance imaging to look at the cross-sectional area of the lumbar extensors, and here we've got the right side and the left side before and after training, and he found about a 5% increase in cross-sectional area of those particular muscles after 6 months of training, and the training regimen was one set with an 8 to 12 repetition maximum load, so 1 time per week. So not high volume training at all, but high quality training. The intensity was there. And then some work, again from Syracuse, Yi-Hua Lee was interested in in partitioning this out a little more carefully and showed that individuals training 1 time per week and 3 times per week both had an increase in the neural drive to the muscle after training compared to controls. Kind of interesting, pretty close, 34% increase following 3 weeks of training, 44% during 1 week of training. So we're increasing the neural drive, right? So the studies are starting to show now that, you know, after a certain period of time, we're increasing neural drive to the area. We're also increasing the morphology of the area. This is at 75% of a maximum voluntary contraction. So we took an absolute amount of force, asked these participants to do that before the exercise training, and asked them to do the same amount of weight after the training. So, you know, you're stronger, so it's a little easier. And what we saw was a reduction in the neural drive by 28% in those that trained 1 time per week, 39% 3 times per week. So fewer motor units needed to be recruited to lift this constant amount of weight after training compared to before training. And when looking at the cross-sectional area, there was a 8% increase in cross-sectional area training 1 time per week and 15% training 3 times per week. So a little bit greater improvement in morphology. And I think the summary slide here illustrates the importance of that. So let's consider first the improvement in functional capacity or isometric torque output or strength. The strength of these muscles, training 1 time per week or 3 times per week. Torque was 31% for both of these groups, but the improvement in torque was due primarily to an increase in the morphology of the muscle, the cross-sectional area, as opposed to the 1 time per week group, which was primarily neural drive. So, while improvements are similar, 1 time per 3 times per week, if we want to improve the structural integrity of the area, maybe more frequent training up to 3 times per week is what we might want to do. What does it take to maintain functional capacity of this area once it's been developed in the first place? This was a reduced training study where we had a group of individuals who trained initially, but then stopped training. 10 subjects there, and this is the group that stopped training altogether in the red. A group that reduced their training to 1 time every other week, and a group that reduced to once every 4 weeks. And this is kind of interesting. This slide shows that if you don't lose it, you're going to lose it. So after a 12-week period of time, if you stop training altogether, decline in functional capacity throughout the entire range of motion. The group that trained just once a month showed not as big of a decline, and primarily in the more extended portion of the range of motion, they were able to maintain here. And with a reduced training frequency of just every other week, all of these subjects were able to maintain. So the take-home message here is if you have to back off of your training once in a while, as long as the intensity is maintained, you can back off to as little as 1 time per month and still maintain. We've seen this with other muscle groups as well, not just the lumbar extensor muscles. And just like in the aerobic literature, and Doug just mentioned this, intensity is key. we can back off on the frequency, we can back off on the duration of exercise as long as we maintain the quality or the intensity of exercise. And here's a study evaluating bone mineral density. This was the first one. This was with some older adults. I mentioned one of our research interests was exercise and aging. We got to Florida. There's a lot of old people there. It makes sense. At the time, there was a lot of information in the literature on men and women up to 60 years of age. Not much information on men and women older than that. I personally thought we were going to kill some people. We didn't. Yeah, older adults respond to physical activity when properly prescribed just as well as anyone else does. So associated with this study where we trained some people using aerobic exercise only, walking and jogging. Here's aerobic exercise plus some lumbar extension training. And we're looking at relative change in bone mineral density in the body and mid portions of, it's probably around L4. No change in the control group, very little change in the aerobic exercise group, and this is after 6 months. So relatively long duration of training for this particular group. But those that supplemented their aerobic training with some lumbar extension training had a significant increase in bone mineral density. And another bone mineral density study by Randy Braith. He was working with a group of heart transplant recipients. And he placed half of these 16 heart transplant recipients into a training group and compared them to another 8 that were in a control group. Now these heart transplant patients, before transplantation, begin a pharmacologic regimen that helps them accept their new organ. They're on a heavy dose of immunosuppressive drugs. There's some serious side effects associated with these drugs, one of which is it tends to decrease bone mineral density. So you can see in all of these groups, let's see, we got control here, okay, post. So post-transplantation, this is 2 months post-transplantation. You can see that both the control and the treatment group were way down in bone mineral density as a side effect of these drugs that they were taking. The control group sort of stayed, between 12 and 16% reduced from where they were before they began to take the immunosuppressive drugs 2 months earlier, and then, of course, 3-month follow-up, 6-month follow-up. But look at what was happening in the group that exercised, the treatment group. Again, 1 set, 10 to 15 repetition maximum load, 1 time per week. The decline in bone mineral density was reversed. And I wish we had a chance to follow this a little bit longer, but clearly a significant improvement in bone mineral density in these heart transplant recipients who are experiencing a lot of serious side effects associated with the need for a new heart. Now, there are several dozen carefully controlled clinical studies in the literature now documenting the efficacy of lumbar extension strength training on the treatment of low back pain. I want to go through just a couple of them. This was a fairly early one by Sherry Risch, working with us at Florida. She looked at the perception of pain and perception of function in a group of individuals that were undergoing treatment for low back pain. There was lumbar extension exercise added to usual care, and this group was participating in usual care only. No change, if anything. Perception of pain and dysfunction worsened, whereas those who participated in the exercise program improved in that area. This next series of slides is from a study out of Brian Nelson's clinic in Minneapolis, Minnesota, the physician's neck and back pain clinic. They studied 895 patients, consecutive patients, who were in pain for an average of 26 months, so chronic low back pain patients. Their rehabilitation included lumbar extension, exercise training and torso rotation, progressive resistance exercise to muscle fatigue, on an average 18 visits for approximately 10 weeks, twice a week for these patients. And the outcomes that were measured, and I've got a couple of slides here that will show you the results, were strength, pain, physical and psychosocial function, return to work, and healthcare reutilization. So let's take a look at what happened to functional capacity, strength and range of motion. So here we have the men. This was initially, and so notice their level of functional capacity as indicated by isometric torque output was significantly below normal, and the range of motion was just a little over half. And after the training period, they improved pretty close to a normal population with respect to strength and also in range of motion. Range of motion didn't fully return, but it was moving in the right direction. Same pattern is true for the women that participated. They were a little lower in strength to begin with. That's usual. It didn't matter what the initial diagnosis was. Those individuals that had either a good or outstanding, excellent or good results, were about three-quarters of these patients, depending on what the original diagnosis was, whether it was a low back strain or degenerative disc disease, spondylolysis, spondylolisthesis, or other kind of disc syndromes. Return to work in this population, 73% overall. And let's see, healthcare reutilization was greater for those individuals who did not exercise. And it really didn't matter whether you were in the non-workers' compensation group or the workers' compensation group. And a lot of studies have shown that those individuals on compensation of some sort have more difficulty improving, returning to work, and it's not known whether they're more severe cases to begin with or there's maybe less motivation there. So in summary, effective lumbar extension strength training improves functional capacity, muscular strength and endurance, and this occurs through both neural and morphological mechanisms. So we're changing the way that the muscles are being recruited. We're also changing the size of the muscle and the bone density of the area in positive ways. And we see reduction in pain, future surgery and system reutilization and return to work. And so that is what I wanted to talk about with respect to the physiology of lumbar extension training and its efficacy in a clinical population. I think I'm going to stop here. This next series of slides is simply some general information on the prescription of resistance training. Let me just point out that resistance exercise, strength training exercise, is an important component of a well-rounded exercise program that would be designed to produce also improvements in aerobic power, flexibility, and body composition. And that there are a variety of health benefits in addition to the increases in strength that are so common. And for this reason, we like to say exercise is medicine. And this is one of my favorite slides. And just like a drug approach to treating, there's a certain dosage, right, that should be used in the prescription. And we know more and more about the health benefits of resistance training all the time. It wasn't too long ago when the original guidelines for the prescription of physical activity in healthy adults came out. There was very little information included on resistance training. It's because it wasn't that we weren't aware that strength training is important. We knew it was important. We just didn't have very much information. So there's more information now. And I like to show this slide just to illustrate this because with respect to the contribution of resistance exercise to the prevention of diabetes or the treatment of metabolic disorder, you know, one of the things that happens is we increase the number of GLUT4 transporters on the muscle and also the sensitivity to insulin. And this is just one example. We could go on and on and on and on. And I just wanted to make the point that as time goes on, we are learning more and more and more about the health benefits. It's already been mentioned that there's a strong influence of myokines in producing these health benefits. Yes, so less is more, intensity is key. One set of good quality exercise is all that it takes, and it's just not just us in this room that believe that, right? The major organizations associated with guidelines for prescribing resistance training exercise, you know, are all saying, you know, a single set, but good quality is what it takes. And yeah, okay, so you might do, you know, 3 sets instead of 1 set and get a little more benefit if you're interested in something specific, but the majority of the benefit can be attained in 1 set, and it takes 3 times as long, right? It takes 3 times as long. So, and I don't have 3 hours in the gym. Now, I said that at one conference and everyone said, oh, that's obvious. But anyway, it's quality more so than quantity, and if we prescribe too much, it's gonna have a negative impact on adherence, right? If it takes us more than an hour, if we're doing more than 1 set, you know, a high frequency, people are less likely to do it. Some contraindications, of course, especially in patient populations that should be considered. One thing about using resistance exercise in rehab programs, sometimes little higher frequency, little lower intensity makes sense initially until the condition improves and can be considered. And thank you so much for the opportunity to present with you today. If you would like a copy of this presentation, just email me at this address. I'll send you the whole presentation, including the few slides at the end that we really didn't have time to go over. Thank you. Questions?
Thank you very much. We have 1, maximum 2 questions that we can allow before the break. Also 1 bis 2 Fragen, bevor wir dann die Mittagspause machen.
I'm Martin Weiss. Concerning the origin of low back pain, you refer to the functional capacity of muscles and to the structural capacity of spine. As a chiropractor, I strongly feel that the functional capacity of spine is not more important, but more frequent as origin of pain. How do you think about this?
I would defer to your judgment. I believe you know more about that than I do. You know, clearly, it's a very complex biomechanical area. A lot going on in that particular area. And yes, we know that individuals that present with low back pain have reduced levels of functional capacity. So I would concur. Yeah.
Vielen Dank. Eine zweite Frage.
Thanks, Dr. Graves. A great presentation. One question that always pops in my mind when I look at your data is with regard to the EMG activity. It seems to be better in the people that trained less frequently. And it always, I try to reconcile that in mind. It seems counterintuitive because it seems like more practice would result in better motor unit coordination and skill. Have you seen that pattern repeatedly? And if so, do you have any theory as to why that is?
Yeah, that's a great question. And two things come to mind immediately. First, when we compare low-frequency training with more frequency training, while there have been some differences, and they do seem to favor the lower frequency training, I don't think they're statistically significant. They're about the same. The other is that I think in the more frequent training, we are developing hypertrophy to a greater extent and other structural changes to a greater extent. And therefore maybe, relying, more heavily on, yes, that's right. But with these particular studies, a couple things to keep in mind. Relatively small sample sizes. Although we go through a power estimation beforehand and we have sample sizes that are appropriate to test a specific hypothesis, we're not talking about hundreds of patients or participants. And I think that's limiting. And the differences that we're seeing between the low frequency 1 time per week and more frequency training 3 times per week are really pretty small. The most significant changes from my perspective are the morphological changes that are occurring with the more frequent training. Yeah.
Thank you very much.
Okay.